So these are important numbers from the TOG articles, and hopefully this will help with your MRCOG Part 2 revision. This is volume 1 of these important numbers. I hope you'll find these useful, and please give this video a thumbs up and subscribe to my channel if you haven't already, and also leave a comment if there is anything else you'd like to watch on the channel. Okay, so stress urinary incontinence affects 75% of pregnant women. The first line treatment is pelvic floor muscle training. Pelvic organ prolapse affects about up to 10% of women. Risk factors are forceps use, prolonged second stage of labor, large for gestation age baby, third and fourth degree tears. Overactive bladder affects 30 to 40% of pregnant women. Lifestyle modifications like reducing caffeine, modifying fluid intake, bladder retraining all help manage the condition. You can also use medications like the anticholinergics, example oxybutynin immediate release. Urinary tract infections affect up to 8% of pregnant women. Asymptomatic bacteria is the biggest risk factor predisposing pregnant women to recurrent UTIs. A fixed retroverted uterus occurs in 1 in 3,000 up to 10,000 pregnancies. Retroverted uterus is an anatomical variation in 20% of women. 47% of smokers quit within the first trimester, but there is a high rate of relapse. Nicotine replacement therapy can be delivered as a transdermal patch or lozenges, chewing gums, oral sprays, inhalers, microtabs. Smoking is associated with increased rate of stillbirth, placental abruption, preterm birth, low birth weight, and miscarriage. Metabolic syndrome occurs in 1 in 3 women with polycystic ovarian syndrome. Polycystic ovarian syndrome affects 10 to 18% of women of reproductive age. Metabolic syndrome includes central obesity, hypertension, insulin resistance, atherogenic dyslipidemia. 3% of in-flight emergencies are obstetric or gynecological in nature. So the risk of pregnancy following vaginal rape is 5%. Management of sexually transmitted infections include testing for giving HIV post-exposure prophylaxis, post-sexual assault, offer accelerated course of hepatitis B vaccine, offer referral to GP or sexual health clinic. Screening for STIs should be done 2 to 3 weeks after the assault. Neisseria and chlamydia swabs should be taken from site of assault. Well, that's it. Those are the important points in the volume 1 of this revision series. I will continue to share lots more volumes of the following series, and if you found these useful, then do give this video a thumbs up and subscribe to my channel if you haven't already. Also share it with your friends and colleagues, and comment below if you found this video useful and you'd like to see some similar videos, and let me know how your revision for part 2 is going.